Hey, hi, I'm Dr. Stephen Park, and welcome to my Ask Dr. Park teleseminar. Actually, Ask Dr. Park webinar. The teleseminar was many years ago. And tonight we're going to be talking about obstructive sleep apnea, state of the art. And in the second half of the program, I'll be answering as many of your questions as I possibly can. Just as a reminder that the content and opinion in this webinar is not to be taken as medical advice, and that you should talk with your doctor before making any changes to your healthcare regimen. All right, so I'm going to start with a very short presentation, an overview of sleep apnea. It'll be a very quick whirlwind tour of sleep apnea and the state of the art because I could speak literally hours on this topic. But I'm just going to give you a very high level cursory overview of sleep apnea and the state of the art as of today. So what is sleep apnea? So this is a condition where a person stops breathing repeatedly throughout the night during sleep. And this leads to lack of oxygen and severe inflammation and stress, physiologic stress. And this ends up causing significant increasing one's risk of high blood pressure, diabetes, heart disease, heart attack, stroke, cancer, dementia, depression, car accidents, and even sudden death. I mean, that's only the short list, believe it or not. In general, people with severe sleep apnea die about 20 years earlier. So generally they die in their 50s. And I hear patients that come in to tell me that they're about to turn 50 and their father died of a heart attack at age 52. They also have a 4 times higher risk of dying from cancer. And 83% of obese, overweight diabetics have sleep apnea. And it's also estimated that about 80 to 90% of people with sleep apnea are not even diagnosed. So although in general, the more overweight you are, the more likely you'll have sleep apnea, you can be a young, thin woman and not snore and still have severe sleep apnea. So that general rule about the overweight, snoring, fat man with a big neck, that is true, but not always the situation. So why do we have sleep apnea? Now, like many chronic conditions, all the reasons sleep apnea is no different. This can range from your genes, anatomy, your habits, such as what we eat, or things like lack of sleep, environmental toxins, endocrine disruptors, and also perhaps many common medications as well. However, I'm going to argue tonight, just like what I did 10 years ago in my book, Sleep Interrupted, that sleep apnea is rapidly increasing not mainly from being overweight, but from our jaws getting smaller for a number of different reasons. So why do humans mainly have sleep apnea? This is because humans are uniquely predisposed to sleep apnea due to our ability to talk. The upper airway serves 3 important functions. In order of importance: breathing, swallowing, and talking. I came across Dr. Terence Davidson's paper almost 20 years ago, which blew my mind. This paper just refreshed findings that our acquisition of speech compromised our ability to breathe and swallow safely. And he described 3 important anatomic processes in this paper. The first one is called clinorhynchi, or rotation of the splaghnocranium, which is mid-face in the jaw under the neurocranium. And this is where the mid-face in the lower jaw rotates underneath the larger brain cavity called the neurocranium. So notice how the face is more forward in a chimpanzee, and human is more backwards and underneath the big brain. Also, you have what's called anterior migration of the foramen magnum. So foramen magnum is where the spinal cord comes out of the skull. So notice how it's a little bit more backwards in a chimpanzee, but as you go down, it moves more forward. So the front face moves backward and downwards, and the foramen magnum or spinal column moves forward, and that's going to narrow that space right here where you breathe. And lastly, you have what's called laryngeal descent, where the voice box, notice how in a chimpanzee, the voice box is at the same level as the soft palate. So notice how the epiglottis kind of touches the soft palate. But in a human, notice the voice box is further down. And this is what's called laryngeal descent. So you have this space here called the oropharynx, and he notes that only true humans, so only humans have a true oropharynx. Animals don't have this. And the same situation you see in infants as well. When they're born, they have this touching overlap of the epiglottis and the soft palate, and that's why babies can suckle and breathe at the same time. But around 3 to 4 months, that's when the airways start to separate, so the voice box start to descend and separate. And that's maybe perhaps why there's a higher risk of SIDS around that time period too, because they have to relearn how to breathe and swallow separately. Now, there are some exceptions to this rule about humans having sleep apnea. Obviously, we have flat-faced dogs, such as bulldogs, that snore and have sleep apnea, and they even are known to undergo palatal operations by veterinarians. And then in certain horses, during exertion, they have what's called an epiglottic lockup, so they need epiglottic surgery as well. But these are kind of rare. Now, when I was in medical school, I was taught that the voice box drops from level C3. In at the bottom of C3, that's your voice box when you're born. And then up to age 20 right here, it goes to the bottom of C6. But notice how from age 20 to age 80, it drops another full vertebral body length. So it keeps dropping very much slower, but it keeps dropping as you get older. So as the voice box gets lower and lower, the airway gets more destabilized. And that has ramifications in terms of your health and breathing and wellness and the quality of sleep in general. Now, how do we test for sleep apnea? And there's different degrees of aggressiveness, but the most common one to start with are screening exams. And for example, you have the Stop Bang or the Berlin or Stanford questionnaires, and these are used as tools by doctors to screen for sleep apnea. They're pretty accurate, maybe 70–80% accurate, depending on who you question. And in the ERs, they'll use it, or before surgery, they'll use it to see if they need to get a sleep test. The next level up are these oxygen sensors that you put on the finger, also called pulse oximetry. And these are more sophisticated devices. There are also more sophisticated devices using algorithms called high-resolution pulse oximetry, which also measures heart rate variability. So this can actually tell if you've had an apnea, so obviously heart rate's going to increase, and it gives you very nice algorithmic calibrations using the algorithms to give you a calculation of how many times you may have had obstructive breathing episodes. Unfortunately, this is not formally accepted for clinical use or diagnosis. However, dentists are using it quite often to measure outcomes comparing before and after treatment. So currently, a sleep study or an in-lab sleep study, or what's otherwise known as polysomnogram, is still the gold standard to make the diagnosis of sleep apnea. This is me. This picture is me undergoing a sleep study about 20 years ago. Now we have home sleep testing that's much simpler and convenient. Now, this is not that new, but now it's getting much more wider acceptance in our field in sleep medicine and ENT, is DISE, or drug-induced sleep endoscopy. So unlike an office endoscopy where an ENT would typically put a camera inside the nose to take a look at your voice box when you're awake, this procedure is done in the operating room under light IV anesthesia using propofol, like for colonoscopy. It takes about 15 to 20 minutes. And what you end up doing is you're trying to see what's happening when you're sleeping. This is fake sleep, so it's artificial deep sleep, but it doesn't get you into REM sleep, which is the worst part of apnea, is when your muscles are completely relaxed. But it does a pretty good job of figuring out what's going on with your deep sleep. So I'm going to give you 3 examples. All right, so this is a endoscopy where we're starting in the nose right now. This is the large adenoids in the back of the nose, and I'm gonna press play. Okay, and you can see the large tonsils right here touching in the middle, and that's totally blocking. And then I'm gonna go down into the lower voice box, which is wide open. So this child has large tonsils and adenoids, but nothing below in the tongue or epiglottic area. This is another example of a man. We're looking from the nose down into the pharynx. So this is a soft palate here. That's the uvula. And what you'll see is that when he's breathing in, everything goes in properly. But as he's breathing out through the nose, the soft palate here backs up towards the nose, causing blockage. So it's like a valve when you're breathing out. So what these people end up doing is they puff air out through the mouth. So let's see what happens here. There we go. So exhale, inhale, exhale, exhale. So this is a mid picture of the palate backing up, closing off the nose during exhalation. So I call this expiratory palatal obstruction. And I see this quite often in my practice. And this is obviously a good reason for you not to tolerate CPAP or even dental appliances, because when you're trying to exhale through your nose, you're going to open your mouth, air leaks out through your mouth, and you get a leak in your CPAP machine, or the mouth guard won't work as well. This is something to look for if you can't tolerate CPAP, or if you have a history of puffing air through your mouth when you exhale during sleep. The last example is the epiglottis. This is the epiglottis, the top of the voice box. That's your tongue right here. And underneath this little crevice, that's your voice box opening. And notice what happens as you breathe in. It just sucks in like a valve. In, and notice how the tongue is trying to move forward, but the epiglottis is sucking back. And this will cause lots of arousals, microarousals, and sleep fragmentation. This opening is what normal airway should look like. It should be this wide open. And this is another thing that I'm seeing quite often in adults and children, where the epiglottis is flopping back significantly. And oftentimes these people don't have sleep apnea. They just stop breathing a lot and they keep waking up. All right. Now, let's talk about sleep tests. Now, one thing we have to mention is the definition of sleep apnea, and how we diagnose sleep apnea is through the AHI, or the Apnea-Hypopnea Index. This is a measure that we figure out during a sleep test, where we figure out how many times you stop breathing per hour. And by definition, normal is 0 to 5, mild is 5 to 15, moderate is 15 to 30, and anything above 30 is severe. But by definition, these episodes where you stop breathing either totally or partially, called apneas or hypopneas, it has to be greater than 10 seconds or longer. So let's say if you stop breathing 25 times an hour for 9 seconds each, then your score is going to be 0, and you're told you don't have any sleep apnea. But obviously that's ridiculous. And this is the definition, or one of the definitions of what's called upper airway resistance syndrome. So how do you treat sleep apnea? So first you have to start with the conservative options. There are 4 major categories. So the conservative, CPAP, dental appliances, and surgery. So let's talk about conservative options. So this includes weight loss, sleep positional therapy, nasal breathing improvement, stress reduction, and also 3 scientifically proven techniques, including myofunctional therapy, acupuncture, and didgeridoo. Interestingly, these 3, myofunctional therapy, didgeridoo, and acupuncture, they all were found to have studies showing that on average, they lowered the severity of sleep apnea by 50% on average. And in addition, there was a meta-analysis from Stanford looking at myofunctional therapy. And overall, this is where they combined all the available studies out there. They found that overall, there was a 50% drop in the AHI in adults and 60% drop in children. Now, these positive airway pressure devices, or CPAP, and there's different other names like BiPAP or AutoPAP or AutoBiPAP. Anyway, they're all positive airway pressure devices that blows general air pressure through your nose or mouth, or a combination, into your throat to keep your airway open. These are usually recommended first by sleep doctors, and there are, like I said, there are many variations, and all have their pros and cons. One important point, however, before deciding to try a different type of machine, let's say going from a CPAP to a BiPAP, is that you have to go over the basics first. For example, the mask issues, the whole suspension option, nasal breathing observation. Important to keep your mouth closed, because that's the most important thing that's going to decide whether or not you can actually benefit from CPAP. And in my mind, optimal nasal breathing and keeping the mouth closed is the most important factor for optimal CPAP use, much more than trying a more advanced model. And I talk about this much more extensively in my book, Totally CPAP, which you can get on Amazon. Now, there are 3 broad categories under dental devices, and this is a huge talk in itself. I'm just going to go over it really, really quickly. The most commonly known about devices, and what's also recommended by the American Academy of Sleep Medicine, are what are called mandibular advancement devices. This is another good option for people with mild or moderate sleep apnea, but not for severe. And the American Academy of Sleep Medicine recommends this as an equally effective first-line option in addition to CPAP for mild to moderate sleep apnea. So for this, you have to find a trained dentist that can make these devices for you. They're custom-made appliances. There's an upper and lower piece. And essentially the bottom part just slides forward gradually to open up the airway by putting your tongue forward. Now, there are some potential issues that may arise, such as TMJ problems or bite changes. But in my experience, if managed by an experienced dentist, these problems can be minimized. There are also what I call functional appliances, but there's a whole gamut or range of devices out there. This also excludes palatal expanders, and there are various different options offered by different dental specialties. This ranges from traditional rapid palatal expansion to slow expansion. And I've seen all these options work to various degrees. Now, unfortunately, there are no studies comparing one to the other. There's also a certain degree of competition between dentists who promote their own devices, and many do have limited positive data. But again, there are no comparison studies, so I can't say which is better. Now, and the last option is surgery, and this is, I could spend hours talking about this, and that's basically my field as a sleep surgeon. But I'm just going to go down really quickly with the anatomy, what options you have available. So starting from the nose, you have the nostrils, and these are all areas that you can operate on. A lot of people have nostril collapse. You can have enlarged turbinates, and this doesn't show up with the septum, which is opposite the turbinate in the middle. It can be crooked to one side, so a lot of people end up getting turbinate surgery or septum surgery with or without nostril surgery. And you have to take the nose first so that you use the CPAP properly. And also, it's very important to move your nose in general without moving your mouth. One thing to note is that nasal surgery has been found not to improve sleep apnea. Now, in some cases, it may help in very mild cases, but as a general rule of thumb, it's not meant to treat your sleep apnea. However, it does help you use CPAP much more effectively. So one study showed that people who couldn't tolerate CPAP used it 30 minutes on average, and after nasal surgery, it went up to 5.5 hours. And also the average CPAP pressure came down, which is very good too, because that's much more comfortable. And then as you go to the back of the nose and the nasal pharynx, you have adenoids in kids. Rarely you have tumors, but that's really, really rare. Then in the oropharynx, that's the area of the soft palate and the tonsils, and kids and some young adults also have huge tonsils here. Then the hypopharynx is the area below the oropharynx. This is where you have your tongue-based collapse, epiglottis collapse. You can have lingual tonsils at the base of the tongue here too. So you can operate on any of these structures, from the epiglottis, lingual tonsils, tongue-based tonsils, palate, adenoids, turbinates, septum, and nostrils. And that's just the soft tissue. Then you can also do bony surgery. We can move the upper and lower jaw forward. That's the maxillomandibular advancement. Then you can also move small portions of the jawbone forward, such as something I used to do many years ago called a transpalatal advancement, where we put the soft palate forward. I'm sorry, this is not a jaw operation, but put the soft palate forward, and making a little window here and moving the remaining bone forward. And you can also do the same thing with the tongue by making a window here and moving this bone forward as well. That's called a genioglossus advancement. You can also move the hyoid bone, move it either down to the thyroid cartilage or tie it to the front lower jaw. So again, there are all these different variations of soft tissue and bony surgery, or a combination of the above that you can do. So I don't want to go into too much of the details because it's such a huge topic. One of the questions that came in was the issue about, it was David, who asked about why is the success rate of palatal surgery so low, like 50%. Actually, historically, it's more like 40%, but that was about 20 years ago. But more recently, with the more modern, modified palatoplasties, it's more like 60, even up to 70%. And the problem with these isolated procedures is that most people have more than one area of obstruction. So at one level, if you could do the palate, it's possible that you didn't address it aggressively enough. Or if you did address it aggressively, you also may have had tongue-based collapse or epiglottic obstruction. So there's other reasons why you can have collapse besides just that one area. In general, though, having huge tonsils is a very good prognosis for palatal surgery for obvious reasons. And then lastly, historically, we used to have offer patients tracheotomy before CPAP was discovered in 1980. The only other option we had for CPAP was a tracheotomy, where you put a hole through the neck here to bypass everything. And obviously that worked, but not very good for quality of life. Now, I do want to mention one procedure, which is, I guess I could call it state of the art because it's very high tech, and it's a pretty neat procedure. So I was actually involved in 2010 in a clinical research study using the same technology for a different company called Apnea. And it's very similar technology using a tongue nerve stimulator with a pacemaker. And we got some pretty good results in the initial feasibility study, but then for various reasons, it just didn't make it past the second phase. But our competitor, Inspire, got their approval in 2014. So this is the pacemaker device that's implanted under the skin in your chest wall. There's a sensor that used to go into the ribs in a separate area, but now it's combined underneath the incision under the stimulator can device. The wire gets tunneled under the skin, and there's another incision here, and a cuff gets placed around the nerve that goes to your tongue. So every time it senses the breathing in, it stimulates the tongue. Now, the signal is not like electrical shock that you may imagine. It's the same level as what the brain sends to your nerve endings. So you don't feel any shock or anything. You just feel like you're moving your tongue. So the results are pretty impressive. Like I said, they got the FDA approval in 2014. The 94% surgical success rate based on traditionally defined success rates. The average AHI dropped from 29 to 9, so that's a 69% drop. The Epworth sleepiness scale, which is a measure of sleepiness, dropped from 11 down to 6, so anything above 10 is considered significant. And also they did a 3-year long-term effectiveness study, and basically it was maintained. So pretty good results. Now, who are criteria for this procedure? Basically, you have to be over 18. These are the 5 criteria. You have to be over 18. You have to be relatively thin, not too overweight, with a BMI of less than 32. You can't tolerate or you refuse CPAP. So obviously, if you can use a CPAP, this is not an option for you. The amount of central apneas has to be 25% or less on a sleep study. And if you meet all these criteria, you have to undergo the drug-induced sleep endoscopy to see how the soft palate collapses. So if it collapses like this completely, then you're not a candidate. But if it collapses like this, then you are. So front to back is okay. So if let's say you're not a candidate for the Inspire, you can't tolerate the CPAP and you don't want to do surgery, what other options do you have? Now, you're going to see a lot of options available online on the internet. This is called the Excite OSA. This is actually a transoral muscle simulator device. So basically, there's these probes here on the sides of your tongue. This is on the base of your tongue, on the floor of the mouth. And it provides a little bit of electrical stimulation. It's like a nerve stimulation device that exercises your tongue. I think you have to use it maybe 30 minutes every day for many weeks. And they got some pretty good results. Not as good as the Inspire, but it was pretty good. And then you have what's called the INAP. This is a negative pressure device that keeps your tongue forward. And the Night Shift, which is this device that you put on your neck to prevent you from sleeping on your back. So every time you're on your back, it buzzes you to wake you up. So you have all these gadgets, high-tech gadgets and devices. Generally, they're not covered by insurance, even though they have FDA approval. It's unlikely to be covered by insurance because the degree of effectiveness is not at the same level as the more formal devices. And then some of these lower tech devices or these sleep positioning devices like the slumber bump, and I think there's another one called the anti-snore shirt. You just wear it on your chest. You have these huge bumpers that are much bigger than the tennis ball recommendation that you hear from sleep doctors. So it works a lot better. And then there are also many different variations of sleep wedges or pillows or mattresses or beds that incline. Now, this is kind of interesting. This is a wedge mattress pillow where it has a hole at the top of the mattress and you slip your arm underneath and then the pillow that moves across the hole. So it takes pressure off your arm so it doesn't go numb or have pain. And that's one of the biggest problems in people who can't sleep on the side even though they want to. So you'll see lots of other variations of all these gadgets and devices out there. So unfortunately, there's no magic pill, there's no magic device, bullet, or gadget out there for sleep apnea. This is a very complicated topic because you have multiple different reasons why you have sleep apnea. And like I said, I think having smaller jaws, just dental crowding and shrinking, just making everything worse because the smaller your airway, the more obstructive breathing you have, which is causing more sleep problems, which causes more sleep arousals, causing more weight gain, causing more sleep apnea. Just to announce that we actually submitted a paper for publication. It's in review. It looks like it's going to get accepted. And we actually looked at over 10,000 college yearbook faces from the 1930s or 50s, and then compared against modern yearbook faces. And what we found was that modern faces are much more narrow and taller than compared to faces 50 years ago, which makes sense. And I may end up doing another webinar on why our faces are shrinking in a future session, because that's a long, interesting talk in itself. Okay, so in terms of sleep apnea treatment pathway, this is a very high-level overview. Like I mentioned, conservative options, including weight loss, position therapy, optimizing nasal breathing. Again, that's really, really important. Now, whether or not you have sleep apnea, you have to breathe through your nose. There are various over-the-counter non-prescription options that like we talked about. And then you go into sleep evaluation and testing by a sleep doctor. And then traditional pathways of CPAP or appliance for mild to moderate. Then surgery if you can't tolerate CPAP or you can't use the dental appliance. And then with surgery, there are many different pathways as well, of which the Inspire is just one of many. I would also recommend considering a dental evaluation early because by definition, everyone has severe dental crowding and could benefit from early intervention, especially younger children. Now, for people who don't have sleep apnea, who have severe sleep breathing problems, pathways is very similar in the beginning, very conservative options in the beginning. Make sure you breathe well through your nose. One thing about nasal breathing is I also recommend taping your lips together, not just making you breathe better through your nose, but if you still open your mouth, you're going to leak air out through your mouth. So you want to tape your lips. Some people do it this way. I like to do it vertically to keep the jaws from opening because when you open your mouth, the tongue goes back more. Especially with UARS patients, they need to see a dentist because most people with UARS have very, very tiny mouths. Many have also had multiple dental extractions, like 8 teeth removed during braces. So the jaws are very small, very high-arched palate, and very recessed faces. Many of these patients, when I was in practice, underwent sleep endoscopy, and that sometimes revealed epiglottic or palatal issues as well. Now, just because you don't have sleep apnea doesn't mean that you can't benefit from these PAP devices. And honestly, it doesn't work as well as in for people with sleep apnea, but maybe I would just guess maybe 10-15% will find some benefit from these devices, as long as you don't have these valve-like conditions that I talked about, like the epiglottis flapping back with the palate backing up. Okay, now let's go to Q&A. You can put in the questions into the Q&A section. So Anonymous says, do you see the Homeobloc as an effective treatment for OSA UARS, which purports to correct the jaw? So the Homeobloc, the DNA, and other variations, they all do similar things, although the inventors say things otherwise. But in essence, they expand the jaws and also kind of expands the teeth forward a little bit. So, and it kind of straightens the teeth as well and just widens the palate. And so to various degrees, it does work. I would probably not focus on the device itself, but focus more on the practitioner. So from what I've seen dentists who are very good at what they do, and they take very low-tech devices like just using very simple braces and traditional palatal expanders, and do just as good of a job as people using these very fancy gadgets like the DNA or Homeobloc. So I think there is value in these devices, and they do have some limited published data too that support it. Palatal expansion historically has been shown to help with sleep apnea. So in children, it was found to be equivalent to tonsillectomy. And there's some limited data for adults as well. So this idea that you can't expand your palate in adults, that's been totally debunked. Lindsay asks, can you give a brief summary of the clinical guidelines what the clinical guidelines are for diagnosis of pediatric sleep disorders? Yeah, so from a practical standpoint, the sleep study is scored a little bit differently. So in children, anything above 1 is considered abnormal, the AHI above 1, because they're much more sensitive to these breathing pauses as opposed to adults. Some hospitals use 2, but for the most part, most centers use level of 1. 1 to 5 is mild, 5 to 10 is moderate, and above 10 is severe. Now, with children, it's a little bit more straightforward, but because for the most part, if you come to see an ENT, typically around ages 3 to 5, most are going to have very large tonsil and adenoids, and that's what ENTs take care of. They take out the kids' huge tonsils and adenoids, and for the most part, they do very well. Now, there's some hesitancy recently, especially since there was a paper, I think about 6 or 7 years ago, showing that like 30 or 40% of these kids resolve on their own by doing nothing. Despite the fact that the kids who got the surgery did much better clinically too. So I think there's been more of a hands-off approach recently, and the pendulum keeps swinging back and forth every 5 to 10 years in our field. I think right now the trend is probably heading a little bit more towards being conservative. There are also various concerns about the tonsils being part of your lymphoid system or your immune system, and I'm not going to get into the pros and cons of that. Besides the fact that there are studies showing that your immune system improves after you take your large tonsils because you sleep better. And also in children, I see a lot of children with epiglottic issues that are usually not picked up. So I can't say that all kids should undergo sleep endoscopy, but if you're not responding to the traditional treatment options, then you have to look for these unusual things like epiglottic obstruction. That's called laryngeal militia. Okay, Christine asks, is it normal to get congested from lying down at night? Drains when upright. Yeah, so in general, if you're healthy, you should not get congested when you lay down because your nervous system, the involuntary nervous system, has a way of constricting the blood vessels to regulate not just your blood flow, but nasal breathing as well. But then when your nervous system goes awry due to aging, or especially with medications, especially something like high blood pressure medications, it lowers your sympathetic tone, and that's what constricts your blood vessels in your nose. And so if you have any neurologic disorders from, let's say, sleep apnea or a neurologic condition or prescription medications, then it's not going to regulate that nasal blood flow in a proper way. And also, if you have a deviated septum, that side that the nose is more congested is going to be on the side of a deviated septum. So when the turbinate gets swollen, that's going to get more swollen faster on that side, especially gravity down. So if you lay on the other side, the blood drains to the other side, but you have more space here on that side. Another anonymous, what about MSC such as done by Dr. Moon? Well, that's another variation of the surgically assisted palatal expansion. There's 4 or 5 different names, like they're like EAST, MSC, and different dentists, they've named it different with different acronyms. They all have value because whether you do it quickly or very slowly using a laser or just regular saws or whatever tool you use, you're trying to get the same result. And so again, there may be studies comparing these two options, but it's going to be really hard to do these kind of studies, trying to get these surgeons to cooperate and to like do a head-to-head comparison, unlike these drug trials. So the problem with one of my frustrations with dental appliances, even though I do believe in them, it's not a cure-all for everyone, but it's another complementary way of helping people with sleep breathing problems, and maybe just one of many options that you're going to need. But the problem with these appliances is that you don't have any comparisons between two options. But like I said, you can be very good at using one that you're very familiar with. Vasanta asks, hello, Dr. Park. Was curious if you could talk tonight or sometime in the future about tinnitus and how to treat it. Oh, sorry. The topic for today is sleep apnea. However, one thing that I've noticed is that patients always say, when I sleep better, my ringing gets better. And that kind of makes sense. So one of the ways I think about tinnitus is that it's an inner ear migraine that manifests, well, it's a migraine that manifests in the inner ear, as opposed to a headache or a sinus migraine. If it happens in the inner ear, then you get symptoms specific to that body part. So a migraine in the sinus will give you pain, congestion, post-nasal drip, headache, congestion, post-nasal drip. In the stomach, you get diarrhea, constipation, bloating, pain. In the ear, you get either hearing loss or ringing or dizziness. And so I don't discount the traditional explanations for tinnitus, but and I would recommend doing the traditional treatment options that the ENTs recommend. but at the same time, you have to address the sleep. Otherwise, you're not going to make any progress. So I broke my my rule. I answered it, but I always, as you can tell, I bring everything back to sleep apnea, no matter what condition you have. Okay, Varun asks, what is your opinion on Xylitol nasal spray as a means to reduce nasal congestion for OSA? So if I remember correctly, xylitol is a sugar compound, and anything that has either salt or sugar is going to kind of shrink the membranes, like salt water. That's why you can breathe better when you go swimming in the oceans as opposed to fresh water. So all these options to help shrink the membranes, they do work, but they're temporary. So you have to do it on a regular basis. And so my general recommendation is, if it works, keep using it. Probably not a good idea to do it for the rest of your life, like 5 to 6 times a day, because now you're going to get addicted to it. So rather than just covering it up with these sprays, if it's really bad and causing other health problems, get it addressed more definitively by seeing an allergist or an ENT. Okay. David asks, can you talk about the use by some doctors of 4% desaturation and the result of visiting hypopnea, especially in women? Yeah, so what David's talking about is that different sleep labs use different thresholds for scoring what's called hypopnea. So just to refresh your memory, apnea means you stop breathing completely for 10 seconds or longer, 100%. Hypopneas mean you stop breathing for more than 30 or 40% drop in the amplitude, the airflow of the nasal airflow, along with either a 3 or 4% lowering of oxygen levels, or your brain waves wake up. So either 30 or 40% drop in your airflow and 3 or 4% drop in your oxygen levels with brainwave arousals. So different sleep labs use different criteria. And so the criticism of the 4% is that you're going to kind of raise that threshold to pick up these hypopneas, which are more subtle partial obstructions. And obviously that's more detrimental to women, because women have more of these more subtle problems, and kids too. So, you know, I've heard sleep doctors at conferences argue for hours about these issues as to which is better, and the sleep labs, the directors have their logic and reasons as to why they do it. I don't think for some reason the Sleep Academy is not mandating one over the other. They give these sleep labs options as to which one to choose. There may be some other reasons based on the technology or the tools, the sensors they use, or the equipment that they use in the sleep lab. But honestly, the more I practice sleep medicine, the more I've been doing this for many years, what I'm realizing is that the value of a sleep study is becoming less and less important to me. Because a lot of patients I treat don't have any sleep apnea, and they are really, really suffering severely. And so you have to treat the patient, not the numbers. So whether or not you have a sleep apnea diagnosis by sleep study. Now, if you have a diagnosis, that just makes it easier logistically because insurance will pay for it. But if you don't, then that's a lot more challenging. Okay, next question. Steve asks, I use a CPAP machine, but use a full face mask because my nose is usually stuffed up. Hard time keeping up. I have a hard time keeping the mask from leaking unless I tighten it up. Any advice? Well, it's clear that you need to take care of your nasal congestion. And tightening the mask generally doesn't work. In fact, in some masks, it makes it worse because you have to have a certain ideal tightness for the mask to create a seal. So if you tighten too much, you get more leaks. So my recommendation is get your nasal congestion addressed. And these full face masks, because it has a wider surface area, the pressure has to be a lot higher, so it becomes more comfortable. So then you're going to open your mouth more and you get a leak also. And remember I told you about that study showing that people who underwent nasal surgery increase their CPAP usage by 5 hours. Okay, Lindsay asks, can most pediatric ENTs perform a DISE? It's hit or miss. Fortunately, I worked with a number of pediatric ENTs that were trained at Cincinnati Children's Hospital, where they do this quite often. But it depends on where they were trained and what their comfort level is. Technically, any ENT is capable of doing it. It's nothing that challenging. You just have to read about it and just start doing it. And the more you do it, the better you get at it, just like any other procedure. Okay, next question. Christine asks, what is the criteria for UARS what do you need to look for on a PhD to identify UARS? So there are no official criteria, Christine, for UARS. It's a diagnosis basically of exclusion. If you don't have sleep apnea and you have symptoms and you have to find the typical clinical features, then you have to assume that it's UARS. But there's certain things that suggests kind of point towards the diagnosis of UARS, even though you don't have any apneas. It's multiple arousals. So some people I've seen have 20 to 30 brainwave arousals without having any apneas. And also you have very fragmented sleep. If you look at the hypnogram, the graph of the sleep stages, it's very fragmented. Also, for most people, it's going to be much worse when they're on their backs. So that's why most people sleep on their sides. And also, there's some computer algorithm studies that have shown that using what's called cyclic alternating pattern, very technical mathematical formula using Fourier equations, where they looked at sleep stage instability. This Dr. Imano, pioneered this method as well, along with some Italian doctors. I don't think it's being used as much. It was kind of in vogue maybe about 10 years ago, but I guess it's not that practical. And then Dr. Gimeno, in his original UARS paper in the 1990s, he used esophageal manometry. So this is a pressure catheter through the nose into the esophagus, and he found the pressure readings got lower and lower with each breath, and they woke up. And not too many centers do that. I'm sure there are, but actually there's one doctor that I know who's very good, Dr. Gerald Simmons in Dallas. He does this on a regular basis. Steve, I guess Steve, who asked a question about nasal congestion, I do take blood pressure medications. Yeah, my point is that by definition, many of the blood pressure medications can cause nasal congestion. Paul asks, I heard that older toddlers who have OSA may rock back and forth and even bang their heads repeatedly against the crib rungs. True? Why? I'm not sure about that. I mean, that sounds to me more like rocking back and forth. That's could be autism, but again, don't quote me on that. I mean, children, toddlers, they do weird things when they have sleep apnea just so that they can breathe. Oftentimes, they'll also sleep on their tummies with their butt sticking up in the air. That's a classic symptom of breathing problems because they can't breathe otherwise. And even then, they stop breathing a lot. David asks, what's so important, AHI, heart rate variability, or sympathetic activation on oxidative stress? Well, I think they're all important, but the AHI, the heart rate variability, that's measuring, it's the end result measure of what's happening. So the higher the density of these events, the more consequences you're going to have on your body and your brain. And ultimately, now, even with AHI, it's not just how high the number is, but also how long are the episodes when you stop breathing. So what's your oxygen desaturation index? So if you stop breathing for 45 seconds and your oxygen level drops to 50%, that's pretty bad, even though your AHI is mild. So you have to kind of look at a lot of different variables and not just focus on one variable. Okay, Peter asks, I have bad sleep apnea. I have used the CPAP successfully for 7 to 8 years until recently when I started on blood thinners. A few months ago, I developed what seems to be spontaneous nosebleeds. One episode prompted me to go to the ER. Finally went to ENT who cauterized me, but took four visits of cauterizing over 2 to 3 months to stop it. Now, after no problems for a couple of months, there are signs that I may be starting again. Is this exceptional or common? The first thought that I have is that CPAP can cause nasal dryness, and that's why you have to use a humidifier. But any kind of airflow is going to cause more turbulence and dryness. But the fact that it started 7 to 8 years after you start using it means that it's probably something due to something else. Maybe your room got drier for whatever reason. Did it start in the winter time when the heat is on? So I would treat this as a separate problem with your ENT. And then if it interferes with your CPAP use, then you have to kind of work with your sleep doctor, maybe try a different kind of treatment option. All right. Brian asks, 4 years ago, I was diagnosed with sleep apnea and operated on with sinus surgery, EPP, septoplasty, tonsillectomy, adenoidectomy. Wow. And my daytime sneezing fits are totally gone. But I still have a clogged nose, great difficulty getting out of bed in the morning, and the daytime tiredness I've always had. Only after house will I get rashes a day or two afterwards. It's hard to say what's going on with you, Baron. It sounds like you definitely need your nose looked at again. But it's funny. You can undergo these aggressive operations and still have significant areas of obstruction. And so typically with my protocol, I would have you, if you came to see me, I would examine you for to address the nose first with therapy or further surgery. And then while doing nasal surgery, oftentimes I'll do the sleeping-endoscopy at the same time to see what's going on in the throat and then plan on what options to recommend. So if you can just improve the nasal breathing, most people can tolerate the CPAP better. But if you don't want to do the CPAP, then if you qualify based on these other factors, you're qualified for the Inspire as well. So there's a lot of different pathways you can go. But again, it's just hard. Based on what you're telling me, it's hard to make any specific recommendations. Sarah asks, I'm very concerned about my toddler. He sleeps with his butt in the air at age 2. This is what I talked about before. His father had oral ties and a high palate. He was revised for oral ties at 2 weeks and also 1 year due to latching issues. What do you recommend for him? So this comes back to the issue with ankylosing or tongue tie and sleep apnea. And there's definitely a connection between the two, and it's hard to say what causes what. It's probably bidirectional. My opinion, this is just my informal opinion, is that it's not that one causes the other, but it's something higher up that's causing both downstream. So whatever is causing jaw underdevelopment is also causing soft tissue underdevelopment as well. So as you develop as a baby in the mother's womb or just after you're born, if the jaws don't develop, then soft tissues are not going to develop properly either. And so you can do the tongue tie release and keep doing it over and over again. But if you don't address the other issues, I'm willing to bet that your son, I don't know if he's a boy, right? Yeah. Probably has very small mouth and narrow recessed arches. Like most modern babies born these days, it's almost a given that they're going to have dental crowding and these various breathing issues. So if possible, maybe start to go see an airway dentist to consider some kind of appliance therapy. I know he's kind of young right now. I think certain dentists will start around age 3 or 4. Okay, Christine asks, are there many doctors who diagnose and surgically correct epiglottis issues for adults? That's a tough question. I just kind of happened to stumble into it because I started doing a lot of sleep endoscopies. But if you look at the research literature, there are lots of articles, not a lot, but a significant number of articles that have been published about the epiglottis. But most of these are either case reports or very small series. There aren't too many studies looking at huge numbers of epiglottic procedures because it's not something that we look for, and it's not something that we'll do anything about in very aggressive ways. Now, one thing that kind of tipped me over the edge to start to do epiglottic procedures is I went to a sleep conference many years ago, and I heard this Italian surgeon that was doing robotic tongue-based surgery. And at the same time, he was routinely doing epiglottic resections. He was cutting the epiglottis off completely. And most of the surgeons were kind of shocked at what he was doing. And when he was questioned on this, the Italian surgeon said, well, they do much better clinically along with the tongue-based surgery, and I've had no complications. So at that point, I went back to the literature and read everything available about epiglottic surgery. And essentially all the concerns about swallowing problems, aspiration, they were essentially very minimal to none. These concerns are more theoretical because it's been taught that epiglottis protects your airway when you swallow. But for example, there was one study looking at people who had stab wounds where the epiglottis was cut off, or after cancer surgery. And we do a lot of these procedures for cancer surgery, and they swallow fine afterwards. But what they did for these patients was that they got swallow studies afterwards and found that there was no aspiration. What happens is that the tongue takes over. But just because of the historical concerns, it's even when I do these procedures, obviously I don't do it anymore, but when I do them, it's kind of scary because there's always that theoretical risk. And then every time I kind of pull back, so every couple of years I go back and forth, I get concerned. Maybe one person had a prolonged period of swallowing problems, which went away. So that I go back to more conservative stiffening procedures, and then I get less good results with that. So I go back to more aggressive cutting procedures. So I don't have a good answer for you. I think you're right. Pediatric doctors see this a lot more, but they're used to treating this surgeon. And one of the fallacies about epiglotic surgery is that laryngomalacia of the epiglottis, that you outgrow it as you get older. And yes, that may be true, but I don't think so, because I think a significant number actually just morphs into something else, or just not picked up. Varun asks, what are the results of the Montefiore Medical Center study on Homeobloc posted on your blog for sleep apnea? Actually, that study was canceled many years ago. We just couldn't get enough subjects to enroll. So unfortunately, we had to cancel that. That would have been a good study to do to complement some of the other studies like that out there. But I would have expected pretty good results. It's just that we just didn't have enough people interested to do a study. There's a comment here. I have a genetic condition, EDS. I think you're talking about Ehlers-Danlos syndrome, which means I have issues with my connective tissues. He is not diagnosed but suspected. Okay, so your son may have this as well. And so when you have connective tissue disorders, it's not just connective tissues, but because bone and cartilage, ligaments, they all kind of start from the same place. And so you have lax joints, loose ligaments, and the epiglottis is cartilage and has a little ligament there's a glossal epiglottic ligament. And so things are kind of floppy. Now, one thing about the epiglottis is that it's not only, when I see these kids with floppy epiglottis, it's not just positioned backwards, but when I actually feel it or when I cut it out, when I touch it, it's very floppy. It's like tissue paper, not stiff like your ear. So something is happening to the cartilage itself. And I think, again, it's not a specific cartilage problem, but it's a downstream product of whatever is causing this problem. And I think it's beyond just the conventional things that I talk about, like lack of breastfeeding, thumb sucking, mouth breathing. And I've also added maybe fluoride use because it prematurely hardens the bones. But now I'm going to also add other things like toxins, endocrine disruptors. There's so many different ways to kind of disturb development, when you're in your mother's womb or even afterwards. So something is happening to our babies right now. That these conditions are just exploding exponentially. And maybe I'm biased because I'm in a hospital setting. I was in a hospital setting and I saw all these kids. But honestly, like every other one of my personal friends, young children, have very similar issues. So I'm not surprised. And it's getting worse decade by decade. And we're going to address some of these issues in the upcoming webinars as well. So that's it for tonight. Next week, I'll be talking about natural foods and supplements that not only help you to sleep better, but also to be healthier in general. So stay tuned. Until next time, hoping you can breathe better and sleep better so that you can live better. Goodbye.